Hi, this is Tarek Youssef. Uh, I'm talking today about one of my cases. It's a nanophthalmic patient. It's actually a family of few members that I did the rise the same way. Nanophthalmos is a condition where there's a very small axial length of the eye. This lady had 16 millimeters size eye, and the normal is 24. She needed a lens power of uh, 55 diopters, and they don't make it except up until just 40 diopters, the maximum that's available from the companies in North America. So we have to implant two lenses, what we call piggyback implantations. So at this stage, I'm doing just a routine phaco emulsification. Doing a capsulorhexis to measure about 5.5 millimeters in diameter using the heat rotor forceps, followed by this is hydrodelineation and hydrodissection to split the layers of the lens into different manageable, safer to remove layers. The nucleus will be easily removed with the fake emulsification using the chopping technique, although this is actually mainly irrigation aspiration, as this lady didn't have cataracts. It's a clear lens extraction uh, to solve her problem of nanophthalmos with very small sized eyes and angle closure. So the fake emulsification is done very quickly, followed by J cannula cleanup. And it's very, very important actually to clean up the capsule very well here. The J cannula is proved to be safe and effective to do that. And it cleans up the layers that you don't actually see to clean. Uh, because capsule opacification here is it can lead to interlenticular opacification and can lead to major decrease in the vision after surgery. So the capsule is inflated with viscoelastic. Here it's Helan, and the first lens, which is the high-powered lens, it's a plus 30 Tecnis acrylic ZA 9003 is implanted into the capsular bag. The thicker lens was always go for in first because this is where the more space is. So you implant the bigger lens into the capsular bag. Uh, and after that, I'll do a wash for the viscoelastic, the Helan from the capsular bag and remove any cortical material that's left after the J cannula cleanup from the capsular bag. Because after you implant the second lens, you're going to have hard time to get into this space. So after that, we'll inject more Helan into the capsular sulcus, and the second lens will be implanted, which is the uh, same lens, but it's the power of the 25 to complete the 55 diopters that's needed. And usually warn the patient at this stage because they're going to feel a little bit of pressure because the haptic is actually pressing on the ciliary body, ciliary sulcus. So the second lens is implanted into the sulcus, and the we just position it in place and try to avoid the lens trying to go into the bag, as this will increase the intercapsular opacification. The uh, the viscoelastic will be removed with the irrigation aspiration, and the pupil was closed using carbostat to try to keep the lens in place the first post-operative period and close to avoid the capture of the optic of the second lens while the pupil is getting smaller. Uh, so carbostat will be injected, and you notice that the pupil will start to get smaller as in the coming few seconds. As soon as it crosses the optic edge, we are safe, and the wound hydration and Avelox injection into the wounds to seal the wounds and protect against endophthalmitis. Some of it will go into the intraocular area. And the patient was actually seeing immediately on the table after I implanted the second one, and she started crying. Thank you very much for watching. Bye.